Thank you very much, and I very much appreciate the invitation to speak with you this afternoon about NIRS and cerebral oximetry. So what we're going to discuss is the advances in technology, which has increased the accuracy of NIRS monitoring. So with that, you're all familiar with these abbreviations. We, of course, talk about oxygen, O2, and then the saturation is what the NIRS monitor actually monitors. And some people describe it as regional oxygen saturation. But what it means is that it reflects the supply and demand of oxygen in the brain by calculating the oxygenated versus total hemoglobin. So if the monitor displays a value of 70, it means that 70% of the hemoglobin in the tissue under the sensor is oxygenated. So here's the oxygen molecule. This is the hemoglobin molecule, and it absorbs light differently depending on whether oxygen is bound to the heme group or not. So it actually has a different color when it's carrying oxygen than when it's not carrying oxygen. However, saturation of hemoglobin does not determine tissue oxygenation. It's actually the partial pressure of oxygen that drives movement of oxygen from the vascular space to the actual cells. And in America, we measure this partial pressure of oxygen by millimeters of mercury. I don't know if you do also. Some kilopascals, yeah, so. But what a cerebral oximeter actually does is it allows you, it gives you the information on the saturation value over here, the percentage of hemoglobin saturated. And if the monitor is showing a saturation of 70, it correlates to a PO2 of approximately 40, which is normal. And of course, any saturation decrease would have a corresponding decrease in the PO2. Now, P50, the 50% saturation of hemoglobin level, corresponds to a PO2 of approximately 27. And this is where the hypoxia of the tissue really begins to start. Now, what does the monitor actually look at? Well, this is the actual physiology of cerebral oximetry. You're all familiar with pulse oximetry, the sensors that go on the fingers. And pulse oximetry, although it uses the same principles of physics and light absorption, only provides information on the arterial saturation of the blood. And a normal value for arterial saturation would be 90 to 100. Now, if we wanted to get an actual saturation measurement of the brain, we could insert a catheter in the jugular vein and put that catheter tip into the jugular venous bulb, which is the collection area in the brain where all the venous blood comes back. And this would allow us to get an actual venous sample of blood from the brain only. And the normal range for the jugular bulb is approximately 50 to 70%. The brain is a high oxygen consumption organ. It's the highest in the body. And the saturations are typically lower than venous saturations in other parts of the body. Now, the cerebral oximeter, right here with the sensors on the forehead, is a regional saturation measurement, and the monitor can't tell the difference between blood that's in the arterial system and the blood that's in the venous system. So it's a mixed value, and you can see that the monitor will give you a saturation value that's slightly higher by about 10 points than the absolute venous value. However, this is highly invasive. Oops. Where did I go here? So this is highly invasive, of course, and technically very difficult, challenging to do. The foresight cerebral oximetry value is continuous and non-invasive. Very easy, very simple to do. Okay, so how does the technology actually work? Well, this is the sensor that goes on the patient's forehead, and you can see here at position 1 is where the light emitting diodes or light bulbs actually emit the light. And we take 2 measurements. We take a measurement at position 2 and a measurement at position 3, because the light moves through the tissues in this elliptical or banana-shaped pattern. We take a shallow reading here to eliminate the effect of the superficial tissue. The hemoglobin or blood in the skin obviously doesn't add to the oxygen of the brain. So we need to subtract our reading here in order to get brain tissue only. So two different measurements and 2 different distances. Okay, so do these cerebral desaturations actually happen during surgery? Well, the technology was developed in cardiac surgery, and so we looked at the literature in cardiac surgery. You can see all the different cardiac surgery procedures here. And indeed, a significant number of patients do experience cerebral desaturations during surgery. And of course, it increases with the difficulty of the surgery. For example, in aortic arch surgery, replacement of the aortic arch, you can see that up to 75% of these patients experience hypoxia during the surgery. And we really don't know what the results of that hypoxia is. Now, for those of you that are not in cardiac surgery, we also looked at other operations. We looked at thoracic surgery. We looked at single lung ventilation procedures where only one lung is needed or used to support the patient. We looked at spine surgery where the patients are in unusual positions. We looked at shoulder surgery in the upright sitting position, craniotomies, and also even general abdominal surgery. And again, the literature shows us that these patients do experience hypoxia during the surgeries. And probably the most interesting one is this shoulder surgery in the sitting position. In this particular study, 80% of the patients experienced hypoxia during the operation. So then we asked the question, do these desaturations actually cause harm? And yes, of course they do. The literature again shows us that there's a significant injury to the patients if they have hypoxia during surgery. This is for those of you that are intensivists, this is a very interesting study that was done on post-operative cardiac surgery patients. And you can see in the immediate post-operative period, 53% of the patients experienced these cerebral desaturation events or hypoxia in the intensive care unit. 47% did not. When they looked at the complications of these patients, you can see post-operative nausea and vomiting. The patients with the hypoxia 17% had postoperative nausea and vomiting. More interesting is that the patients with no hypoxia in the postoperative period had no post-op nausea and vomiting, no complications at all. They also looked at their patients that died, and of their patients that died, 18% were in this hypoxia group. But again, when there was no hypoxia in the intensive care unit, there was no death among those patients. So very dramatic results showing that this hypoxia does occur and it does cause harm to patients. Now, does reversing the hypoxia, treating the hypoxia, improve patient outcomes? And again, the literature is quite clear that yes, it does. So why Foresight Elite or cerebral oximetry? Well, managing desaturations is about knowing when to intervene, when to treat the patient for hypoxia. And knowing when to intervene or not intervene is all about the accuracy of the monitor. A doctor can only make good clinical decisions based on good information from the monitor. The monitor doesn't improve the patient outcomes, it's the doctor's decisions and the treatment. So Foresight Elite is the most accurate, reproducible, and consistent tissue oximeter available. Okay, so in summary, these desaturations or hypoxic events definitely occur. We know they cause harm, and the complications associated with hypoxia are very diverse, from post-op nausea and vomiting to cognitive dysfunction, extended time on the breathing machine, or even extra days spent in the hospital just recovering from hypoxia. As a doctor, you can stop them. It doesn't require any different techniques or treatments that you're not already using. But only if you know about them. You have to know that these hypoxic events are occurring. And by knowing them, you can make good clinical decisions on how to properly treat the patient. So, looking at the technology, Foresight Elite uses 5 wavelengths of near-infrared light. This is very important because it allows us to collect more and better data, and I'll explain what that means. We have unparalleled accuracy. The computer program inside the monitor allows us to process that data to give accurate saturation values. We have the deepest penetration of light to interrogate the maximum amount of tissue. Oops. And then, in addition, we have computer programs for both pediatric patients and adult patients. And that's very important because obviously the anatomy of a child is significantly different than the anatomy of an adult. So you wouldn't want to use an adult monitor on a pediatric patient. So how does it, skip that one. So let's skip that one. So how accurate is the monitor? Can you be confident that the saturation value that the monitor is seeing or reporting is actually the true saturation value? So we did studies, and here was the number that was being displayed on the Foresight monitor, and we compared that to actual blood samples, saturation values on actual blood samples from the brain. And if there was a perfect correlation, all the dots would fall on that 45-degree line. Okay? So you can see we're not quite perfect, but we're very good. The accuracy of the Foresight in the abnormal range is about plus or minus 1. Okay. Now, are other devices similar in accuracy? Well, the answer is no. So here's the device that you're actually using, the InBose technology. And you can see the InBose is in the black dots, and you can see that the accuracy of the InBose is not nearly as good as the accuracy of the Foresight. Now, why is that? Well, the InBose only uses 2 wavelengths of near-infrared light to make its calculations, and the Foresight uses 5 wavelengths. So as I said earlier, we get more and better data, and our computer then allows us to make far more accurate saturation calculations. It's not that the device is defective, it's not a bad machine, it's simply limited by physics and mathematics with only 2 wavelengths of light. Now, is that important? Well, yes it is, because for example here, if your monitor was showing a saturation of 50, which is hypoxia based on our oxyhemoglobin dissociation curve, the actual blood samples tells us that yes, it is indeed 50. So you can be sure when you treat the patient that you're treating the patient correctly. If you look at the other device, a saturation of 50, well, for example, here, this one was at 30, the monitor was showing a saturation of 30, which is really critical hypoxia. But the blood samples were showing, but the blood sample was actually a saturation of 50. Okay? So a very significant difference. All of these dots here below this 45-degree line are what we call false positives. In other words, the monitor was giving information that hypoxia was occurring when indeed the patient's condition was normal. So it's a serious problem. Comparing, these are some of the other devices. I don't know if you have them here in St. Petersburg, but so how important is that? Well, here, this is a comparison of Foresight to InBose. The Foresight is the green line up here, and the InBose is the blue line down here. And the accuracy of these monitors is reported at 1 standard deviation. And 1 standard deviation in statistics covers 68% of the population, or 2 out of 3 people. This would be the accuracy 2 out of 3 times. Now, we don't think that that's good enough at Foresight. We believe that 2 standard deviations, which covers 95% of the population, is far more useful. And so here you can see that the 2 wavelength monitor, if you, for example here, if you have a saturation of 50, the number that's displayed on the monitor could be as high as 70, which is normal, or the true value could be as low as 30. And you don't know. As a doctor, you don't know which one is correct, right? If you compare that to Foresight, you can see that the number stays very close to the true value. So, and again, it's only because of mathematics and physics. It's not a defect in the product. It's just limited by what it can do. So, I'm going to speak now about how the technology actually works for those of you that are not familiar with it. And what's important is that the monitor has to compensate for other things that absorb the near-infrared light to give an accurate number for the hemoglobin saturation. And the primary issue is melanin, and melanin is skin pigmentation. So I don't know if you have patients of different skin colors here in St. Petersburg, but in the US we have patients that have very black skin, people from Africa, and we also have people with very white skin. people from Norway and Sweden. Yeah, so how does that work? Well, so here's how we actually do it. So these are the 5 wavelengths that we use: 690, 730, 770, 810, and 870. And this is all near-infrared light, which our eyes can't see. Below 650 nanometers is visible light, the light you have in the room. Okay? Obviously, it doesn't go through skin or bone, so it's not usable for this technology. On the other end, the maximum wavelength is 900, and you can see here that the absorption of light by water, H2O, goes very high after 900. So all this light would be absorbed by the water instead of the hemoglobin. So we're limited to 650 to 900. That's our window that we work with. We start with wavelength 810. And at wavelength 810, right here, you can see that hemoglobin with oxygen and hemoglobin without oxygen absorbs light exactly the same way. So you can't tell the difference. You don't know if it's oxygenated or not oxygenated. But it does tell us then the total hemoglobin. We know how much hemoglobin is actually there. We also make measurements for melanin or skin pigmentation, how much light is absorbed by the skin, as well as bilirubin. I don't know if patients in liver failure have high bilirubin. That also absorbs the near-infrared light. And then there are other things, background tissue properties in the brain, lipids, things like collagen, that absorb the light. So we use this wavelength 810 to determine the total hemoglobin, light absorption, versus the light being absorbed by the other tissue properties. And then we compare that to these other 4 wavelengths. And you can see that at each of the wavelengths, there's a different light absorption amount by all the different substances we look at. And by making comparisons for all of these, that's how we calculate the saturation value. So with the InVos device that you're currently using, it only has wavelength 810 and wavelength 800 or 730. So it can only make one comparison, whereas the Foresight can make 4. And that's where that accuracy comes in. It just makes more calculations and more using more data. So again, here's how it works. You see the oxy and deoxyhemoglobin here. This is the amount of light that's absorbed, and the background tissue properties and melanin. And it's basically a pocket light. You can see that the light comes on at this wavelength, and it's measured here, and we get a reading on how much light is absorbed by each of these different substances. And we do that 5 times, and that's how the technology actually works. So what's also important to know is that unlike a pulse oximeter, with cerebral oximeter Foresight, no pulse is required, because we can determine both venous deoxygenated hemoglobin as well as arterial oxygenated hemoglobin. And a pulse oximeter only calculates or only can measure arterial hemoglobin. So very important that no pulse is required. Okay. So now, talking about the depth of penetration of the light, how far into the brain does the light go? Well, the mathematics is easy. It's 1/2 the distance between the light source and the light detector. So for Foresight, here's our light source, our emitter, and our deep detector is at 5 centimeters. So the depth of penetration of the light is 2.5 centimeters. So that's a fairly significant distance into the brain that the light is able to go. And then the short measurement for the skin is 1.5 centimeters for a depth of 0.75. And that's shown in this picture. Okay, so again, here's the light source, here's the measurement of the skin, and here's the measurement of the brain. And we subtract this from this reading so that we only get information on the brain. Now, is that important? Well, yes, that's important because studies have shown that a significant number of patients actually have depth of penetration or depth of the brain greater than 2 centimeters. So this was a study that was done using CT scans, measuring at R3 and L3, and you can see that a significant percentage of the patients, the distance from the skin to their brain was more than 2 centimeters. Yeah? And if that happens with, for example, the INVOS, which only has a depth of penetration of 2 centimeters, you would not get a reading, or you would get a false reading. You need this 2.5 centimeter depth of penetration to actually get to this part of the brain. Okay. Now, in addition to the brain, this is where the technology started. We've also made new computer programs for other parts of the body. So you can now measure the tissue oxygenation in the skeletal muscles of the legs. You can measure it in the arms, and also here on the flank or the sides of the patient, which would give you an indication of the flow of blood through the kidneys. Right? And because the light moves differently through muscles than it does brain, you need a specialized computer program to change the accuracy of the calculations. Okay, well, here's a good example. So, as I said, we have a large number of patients in America with very dark skin. And you can see this patient here has dark skin with actual INVOS sensors on the head. And you can see the INVOS monitor here was showing saturations of 23%. Okay. Now, most brains would be dead if the saturation was as low as 23. Okay? So these doctors didn't believe their INVOS number. They took these sensors off and put Foresight on, and that, look, okay, the numbers were actually normal. Okay? So why? Okay, same patient, exact same conditions, why the difference in numbers? And the answer is it's just the INVOS is limited by mathematics and physics. It cannot make enough calculations to compensate for the patient's dark skin color. The light is absorbed by the skin, not by the hemoglobin. And INVOS doesn't correct for that. So in another study, same question. This was in Washington, D.C., and they looked at over 3,000 patients, African American patients with dark skin versus Caucasian or white skinned people. And again, their data shows that the dark skinned people had much lower readings. And this is just not possible because the condition, the physiology of black patients is the same as white patients. And so again, they didn't believe their monitor. They took Foresight, and here's what they saw with Foresight. After only 100 patients, they looked at black patients and white patients. And lo and behold, the readings on black patients were exactly the same as white patients. So again, this just proves that the foresight is able to eliminate the effect of dark skin from the readings, so that when you make a decision to treat the hypoxia, it's a real number, not a false positive. Same situation with bilirubin. This was actually in pediatric patients, but it's also in the adult population as well. So again, here is INVOS, and you can see that patients with normal bilirubin versus high bilirubin, the difference in the numbers is significant. Here with foresight, we had the same issue. So we took our algorithm, our computer program, and readjusted it so that it would compensate for the bilirubin. And here's what you get. So again, patients that were normal versus patients with high bilirubin had the same readings. The foresight is able to eliminate the errors caused by bilirubin. Okay. Now, how do you interpret the numbers? Well, it's actually quite simple and straightforward. Any saturation below 50 should be treated immediately. Okay? That indicates hypoxia. Again, going back to our oxyhemoglobin dissociation curve, it would tell you that the partial pressure, or PO2, of the tissue is probably around 27, and you would want to treat that right away. Any saturation between 60 and 90 is considered normal. You wouldn't have to treat that at all. There are two cautionary values. 90 to 100 is considered cautionary value because it indicates that there's no extraction of oxygen from the hemoglobin to the tissues, right? There's no difference between the arterial and the venous blood, which means no oxygen is being used by the tissues. So this happens frequently in patients with septic shock that have very high cardiac outputs, 12, 14 liters per minute. The blood is moving through the brain so fast, there's no time for the oxygen transfer to occur. Likewise, 50 to 60 is considered cautionary value. This is limited hypoxia, small hypoxia. And patients will tolerate 50 to 60 for a certain period of time. But you wouldn't want to keep the saturation in that range for extended period of time, more than, say, 30 minutes. So, very simple way to interpret the foresight numbers and make clinical decisions. This is the literature showing that the effects of hypoxia at the very low values. Not that important. Now, what are the treatments? What are the treatments for hypoxia, as indicated by the foresight cerebral oximeter? Well, the first correction is to make sure that the blood is actually flowing to the head. And you can do that by adjusting the head position. Okay? You can adjust the cannula position, or even for the surgeon to change the position of the heart. You can increase the supply of oxygen by increasing the carbon dioxide, which can significantly increase the flow of blood to the brain. You can increase the cardiac output, or flow from the heart-lung machine. You can increase the mean arterial pressure, increase the amount of oxygen the patient's breathing. You can use drugs, or you can even increase the amount of hemoglobin in the blood by a blood transfusion. You can, other treatments is to reduce the demand for oxygen, and you can do that by increasing the anesthetic depth or decreasing the temperature. So, again, this is just a picture of how the technology actually works. So you can see here, this is the pulse oximeter and the values that are shown on the fingertip right here. This is a jugular bulb, actual blood samples from the brain, and the foresight reading is right here in the green. So again, it's a very, very accurate monitor which very closely tracks the changes in tissue oxygenation. So with that, I'll conclude. Thank you very much for listening. It was my pleasure to be here today. If you have any questions, please feel free to ask me. Thank you.
Thank you very much.
Thank you.
For your presentation. It's very convincing, it's straightforward. Actually, I'm a plastic refractive surgeon.
Yes?
And we use these devices for monitoring the flaps, free flaps, or
Yeah.
could you give us a sight about this utilization?
Yes, it's a very good technology for that use because again, it doesn't rely on a pulse. It doesn't, and of course the survival of the flap is blood flow to the flap is critical for the flap to be successful, and so by constant monitoring. It gives you that saturation value to know that the tissue is being adequately perfused and oxygenated. The only thing is if you're using like an in-bose device, the depth of penetration of the light is too much for in-bose. You're going too deep. I'll have some slides I'll show you. So in order to get good information, you need to have the depth of penetration of the light just right. And here is the in-bose sensors that are offered. They come in 4 different sizes, from adult to neonates. But if you look, the light source, the emitter, and the light detector is exactly the same for an adult patient versus a neonatal, a 3-kilogram baby, right? So one has to be wrong because the anatomy is so different. Foresight offers 3 different sensor sizes with 3 different arrangements from light source to light detectors, which determines the depth of penetration of the light. So with here, I think that the 2-centimeter depth of penetration is too much for a flap, and you would probably get better clinical information using a sensor with a less depth of penetration of the light, and that would use our neonatal sensor, which has a depth of penetration of 1.25 centimeters. Now you could go to the 2-centimeter depth if you had a really large flap, but generally 1.25 would give you better information.
Do we need special programs for this device? Software?
No. Nope. The software is all built in. The user has to program it. There are 4 channels on the monitor, and that diagram comes up, and you just touch whichever spot you want to monitor. So with a muscle flap, you could use either a deltoid muscle or an arm muscle, because that's the tissue that you're basically looking at. And then it automatically programs that channel for that sensor. Okay. Thank you very much for listening.